Dr. Kukoyi will be sharing with us on health financing, past, present, and future.
Good afternoon, everyone. I know that our time is fast spent. I won't want to stand on existing protocol because a lot of people have done that, and I don't want that protocol to crash. So I'd rather align with the previous protocol. Please, let me congratulate ANPMP Oyo State for this very wonderful conference, and particularly for bringing me to this conference 42 years after I left Ibadan as a freshly baked doctor from UCH. Thank you very much for doing this. Healthcare financing, the past, the present, and the future. Well, we all know that AGPMPN metamorphosed into ANPMP. And so, this is a rebranding that we had in August 2021. And when we are talking about the past, the present, and the future of healthcare financing, we must also take this into consideration. Well, I bring you greetings from Ace Medicare Clinics Limited, where I practice in Ota, Ogun State. And I also want to take you back to 2007 when Ogun State hosted the AGPMPN conference. And that was the program brochure then. And of course, a lot of things have changed since then. But here we are in 2022 at Oluyole 22. Let me also remind you that at 2007 conference, history was made because that was the first time we had daily bulletins at our conferences. And of course, that was also the time that the spouse support group was formally inaugurated, which we are all enjoying now. I thought you were going to give us a round of applause for that. Ogun 2007. Well, let me say that for this presentation, there's no conflict of interest. And this is going to be the outline of my presentation. We are going to have a general overview and definitions of healthcare financing, healthcare finance models in the world. That is the global view, Nigeria's perspective, when we talk about the past, the current world, the present, and of course the future, and then there will be a conclusion. So why do we have to discuss healthcare financing? I just said there that it is the cornerstone of the overall health system. And of course, it can greatly impact the quality and access to our services as private health providers. And for all you care, it determines the number of patients that comes to your clinic and also how much they are able to afford when they come. So it is the soul of our business. And of course, we really do a lot of gain by discussing it. What are the core functions of healthcare financing? Number one of this is revenue raising. That is, all the sources of healthcare financing come together. I will tell you all the sources in a minute. And when all these sources come together, of course, there will be a pooling of funds. And it is these funds that the patients now use to purchase our services as healthcare providers. So this is just a representation of what I've just said. We raise funds, pool of funds, then service purchase, and that is when it now comes to our level as healthcare providers. What are the healthcare financing models? I'll quickly go through them. The first model is the Beveridge model, and this one is designed by Beveridge. It's named after him, and of course, he designed the UK's national health system. In this model, government pays everything 100%. Another model is the Bismarck model, which uses an insurance system. And countries that use this system include France, Germany, Belgium, Netherlands, Japan, Switzerland, and to a degree in Latin America. Of course, we can have a combination of number 1 and 2 under schemes. And the last one is the out-of-pocket, which is the direct purchase of health by individuals. I will tell you the influence of that on Nigeria as we go along. Of course, different countries apply one. Can I have, for instance, in America, the 4 models are in use. For veterans in America, it's fully funded by government, 100%. For those that are after 65 years, for instance, their Medicare is like what Canada practice, that is the beverage model. And for working Americans who have insurance, it is a too. But you won't believe this, that a lot of people also in America purchase out of pocket. So America actually has all the 4 models represented. Well, that is just a representation of what I've been talking about. Healthcare, we have private insurance and social insurance as part of the sources. We have donor funds. We have the budget of the country, and of course, out of pocket. I will now show you the relative proportions of these various components. Sorry. Okay. Yes, if you diagram, you can see that the blue area there is of pocket purchase, and that is about 69% of healthcare funding in Nigeria. A lot of implications. It means that a lot of citizens of Nigeria purchase their health out of pocket, and this can be disastrous when they need health. Only about 12% is funded by federal government, about 8% by state government, 4% by local government, and we have the DAH, which is a development assistance for health, accounting for about 4%. So this tells us a lot. Situation that over 69% of the purchase of health is out of pocket. This has a lot of implications for our practice, because if patients don't have money, it really affects the money that comes into our various practices. Okay, let's talk briefly about the national budget. A lot of people have referred to various presentations. There is this Abuja Accord in 2001 that countries should have 15% national budget for health. But what has been the experience in Nigeria? The best we've ever had was 5.8% in 2002. And, okay, thank you very much. Over the years, we've noticed that the national budget to health has been between 4.6 and 5.8%. Currently, in the year 2022, only 4.6% of the national budget is allocated to health. And of course, we all know the implications of that to the health of the citizens and also to our own practice. Most of that that I'll be discussing will be related to private medical. This is the forum where private medical practitioners are. You can see the graph on the right. The lower one is the allocation to health from 2012 to 2021. On top of that is that black line. That is what it should be if we follow the Abuja Accord, which is 15%. You can see that between the two lines, there's a lot of gap, and that gap that is really affecting the availability of funds, the health sector. This is just a tabular form of the national budget from 2014 to 2020. And that column over there represents that is the difference between what we have and what it should be. You can see that we have over 4.9 trillion naira as funding gap between 2014 and 2021. You can imagine what would have been if this funding gap had been injected into the health system in Nigeria. Now, let's talk about health expenditure per capita. That is, how much is spent on an individual in this country. You can see the graph, the linear graph on the left. It's also from 2009 to 2019. There's a steady rise, no doubt. But then, if you compare in monetary terms what this health expenditure per capita in US dollars is, you will see that on the right. For Nigeria, the value is almost $72 per annum per Nigerian. You can go ahead to compare this with what other countries have. Ghana is our immediate neighbor. The health expenditure per capita there is $72. South Africa is also in Africa. You can see that that is almost $5 per capita. Then if you go to UK, 4,000. Canada, over 5,000. Norway, 8,000. Switzerland, 9,600. And the country that has the greatest per capita is over $10,000 is United States of America. This tells you in brief, that how much a country spends on its citizens in a particular year. The lowest is Nigeria, as per this table, now compared with America with over 10,000 US dollars. Out of pocket again, the actual value is represented on the graph on the left. Sorry, it's not very clear. It's about $110. You can now compare the out-of-pocket expenditure as a percentage of total expenditure for other countries. We have South Africa there, followed by UK, followed by US, Norway, China, and Nigeria. You can see Nigeria there with that big amount of out-of-pocket expenditure. I also tried to, this graph tells you how we are doing amongst the nations. The LPI for 2020, you can see that Nigeria is ranking 144 out of 167 countries. In terms of best healthcare. There are so many factors that are related to this LPI. Health financing is just one of them. But you can see here that Nigeria is not doing well at all when you want to talk of best healthcare. We are just number 144 out of 167. Well, this is a table that illustrates how the funds that come in through the budget, through out of pocket and everything, how it eventually gets to us as healthcare providers. You can see that it's a flow from types of funding, OOP, health insurance, government, donors, until it eventually trickles down to our hospitals and clinics. Well, these are just sources of external aids. I mentioned it earlier as DAH. We have the World Bank, you have the USAID, the World Health Organization, UNICEF, BTA, PEPFAR, private philanthropic organizations such as Jimmy Carter Foundation and all of that. But if you combine, they just form 4% of healthcare funding in Nigeria. Well, I now go to the main topic, which is the past, the present, and the future. And I think this best summarizes what we have had in Nigeria. We can refer to the past of healthcare financing as experience, which I'm sure most of us here have gained. Then the present is an experiment. Of course, the future is an expectation. But we have a lot to do for that future, because the future is what we create by ourselves. I want to define the past as the period between maybe 1980 up to 2005. I chose 2005 because that was when the NHIS was launched. And there's no doubt that the NHIS has really affected our practice either positively or negatively since then. The past, which I said is between 1980 or up to 2005, is the era of medical retainership. Of course, the present is a combination of insured healthcare, either social or private, and of course, we still have a retainership coming along with that. And then I'll talk about the battle between NHIS, the HIMCAN, and the HCPAN as we go ahead. The future, like I said, is a creation of the present, and all of us have a role to play in creating a future for healthcare, private healthcare practice in Nigeria. Now, the past, we all know of the economic downturn of 1980 and its effects on public and private health institutions. It was actually at this time also that the World Bank and the IMF also promoted the philosophy of private-public partnership in Nigeria. And a doctor called Ruger wrote a lot about that. During this period, the organized private sector started engaging different hospitals for the treatment of their employees. And of course, as a result of this, a lot of retainership contracts were signed between these hospitals or clinics and the companies. So what became of the retainership? First of all, let's talk about the advantages of retainership. Of course, there is a direct communication between the hospital and the company that is concerned. And usually, there used to be prompt payment, unlike what we witness these days with NHIS. That time, exclusions were few. And even if such exclusions existed, you could negotiate directly with the companies concerned. And of course, this led to fast decision-making on patients' treatment. And during that time, I think relatively the doctor was on the driver's seat. But what challenges befell retainership? There are so many of them. Number one is undercutting and rivalry amongst healthcare providers, which became a very big problem amongst doctors and their facilities. And over time, the retainership system became bedeviled with moral hazard and rising costs. And it was alleged that company employees connived with and received unnecessary care from healthcare providers. And this led to its abandonment in some of the cases. I think our own Dr. Arigbabu wrote something about this, which was published in 2013. So we now come to the present situation. Like I said, the present, I define this that from 2005 up to the present state. We all know that the NHS was launched in 2005 after prolonged and protracted bureaucracy, and the mandate then was to effect universal health coverage by 2015. We are in 2022 now, and you can see for yourself that that mandate is far from being met. Currently, the national coverage of NHS is put at about 5%, which is about 10 million of our population. You can compare this with Ghana, our next door neighbor. Ghana started its NHIS in 2003, and as we talk, they have a national coverage of 64%. That's a very far cry from our own in Nigeria. The informal sector and states are not fully captured in NHIS. And of course, we all know that NHIS started with a capitation of 550 naira per enrollee in 2005. This was upgraded to 750 naira in 2015 during the time of Professor Thomas as the executive secretary. In this slide, I tried to bring to our consciousness NHIS has really affected practice. On the first column, yes. In the first column, you see that's the second column, capitation 550 in 2005 or 6. Capitation in 2022 is currently 750 naira. That's a percentage increase of 36.4. Now, we all know what we depend on to run a clinic. We depend on diesel, we depend on energy, we depend on normal saline, and we depend on our staff, nurses, for example. The diesel in 2006 was 81 naira per liter. Currently, as at the last time, it was 650 naira. That is an increase of 702%. Same thing for energy, almost a 440% rise. For normal saline, which we use every day, there's a 80% rise. And for our staff, represented by nurse there is a 233% increase in the salaries that we pay them. So a cursory look at this will tell us that we are not really doing well when we talk of what we are being paid by NHIS. Well, this is the representation of effect of NHIS HMO on patient mix. I use my hospital for example. In 2005, we had a mixture of corporate 67% and fee-paying patients 33%. But currently, what you have is 11% for corporate, 15% for fee paying, and 74% for NHIS and HMO, that is insured care, which means that NHIS HMO has taken over the clientele. It will have been a good story if the money or the capitation they are paying is worthwhile. But it has actually done two things. One, it has driven away the corporate and individual patients. At the same time, it has reduced the income because you cannot compare the income from NHIS to that of corporate. So it has that double effect on our practice. That example, like I said, is from my hospital. And that is just another graphical representation of that. Now, this is a tripod that I talked about, the NHIS, which is the policy forming organ. We have the Health Managed Care Association of Nigeria representing the HMOs, and of course we have the HCPAN representing us, the private providers. The NHIS is supposed to be an arbiter between the two bodies, but what we are seeing today is actually a fight between those two bodies, and it's also instructive to note that the healthcare management organizations, most of them are owned by medical doctors, and you can imagine why there's so much conflict between HCPAN and HMCAN now. I know there's an ongoing negotiation between the two, but I only hope that at the end of the day, they will come to a realistic stand, taking into consideration the rising cost of doing business, especially medical business in Nigeria. Well, the future, what is our expectation? Like I said, the best way to predict the future is for all of us here to create it in one way or the other. We need to influence what we should expect in the future. And the only way we can do that is to think out of the box. If you continue to do things the way it has been done, we are going to get results. So we know that we have 3 levels of thinking. You either think within the box, you think outside the box, or you think even without the box. So these are my suggestions for the future. We have really to improve the tax revenue in order to improve the national budget, hoping that that would also percolate into the health budget. There's this thing they call the sin tax, which is the excise tax paid on socially harmful goods or services. For instance, alcohol, cigarette, gambling, pornography, and all of that. It is believed that such taxes are intended to discourage or pay for activities that create socially harmful consequences. There are a lot of pros and cons to this, but I think if this is done by government, it will increase the tax revenue. I don't see any reason why there should not be healthcare tax. After all, we have education tax for those who pay tax to the federal government. It is a matter of compulsion that you must pay the educational tax. So why not convince our government to raise something like a healthcare tax? And of course, we have to, either we lobby or we increase our political advocacy so that budgets can be increased, and especially budgets to the healthcare department. And again, we have to lobby such that the capital stroke recurrent expenditure ratio is improved upon. The experience is that for current expenditures, is spent on recurrent matters. leaving just 20 or less percent for capital projects, and we know that that is very insufficient. Well, the NHIS has to be strengthened, either in terms of budgetary allocation to that department, or to make it mandatory for state governments to key into the NHIS. Currently, it is not mandatory. That is why many states have not really bought into the NHIS. And of course, we need to impress it on NHIS to do a proper oversight on HMOs. For instance, we know that many HMOs are private providers. It is the duty of NHIS are brought to book if they refuse or if they delay to pay the healthcare providers. Well, this one is just coming from Ogun State, for instance, and they are selling the insurance for 1,000 naira per person. Well, Ogun State ANPMP is still going to discuss with the state government on how this can happen and how it's going to affect individual practices. Take it to our hands as ANPMP. I think this is very important. And Otazone in Ogun State did this in 2007. We wanted to register Otazone AGPMPN HMO. But along the line, because we are doctors and not a businessman, that plan failed. But I think it's something national can take into consideration and discussion. There's nothing that prevents ANPMPM from its own HMO. In that wise, we can take our future in our hands. Examples abound of professional associations, professional medical associations that have their HMOs. Some of these are in the US. We have the San Joaquin Foundation in California. We have the Physician Association County in Oregon State. So, why not Nigeria? Thought for us, and I think we'll take something out of this. Well, public-private partnership. We all remember in 2012, this idea of a world-class hospital was mooted by a former president, and he set up a committee headed by the private sector guru, Tony Elumelu, which was inaugurated in 2012. This is nothing has been done. I think this is, if this is properly done, I think it will improve on the healthcare funding, which will eventually also come down to us as healthcare providers. There must be a deliberate government policy to encourage private sector participation in the public health system, because this will relieve healthcare funding pressures from government, and either they raise the money through capital markets or through whatever means, it will improve the funds that come into the healthcare funding. And I think I had to rush this because we have lost a lot of time, and I know that we are very hungry, and wherever there is hunger, seem to lose interest in whatever is going on. So, another suggestion most people have made is to have a healthcare bank, which we know that other industries have peculiar banks, like a bank of industry, for instance. There's nothing that stops the government from setting up a healthcare bank. And the advantages of such an entity is that it will be a single-digit rate loan, and it should be exclusive for the healthcare sector, and it should have a long tenure for repayment, up to about 6 to 10 years, which will relieve us of the pressure of repayment. Probably the last suggestion for the future is for us to come together. Mega practices. I know that been discussed for quite a long time, and yet we have not really moved positively in that respect. But if we are able to do that, the advantage of mega practices is that it will spread the risk, it will pull resources together such that we also have access to larger loans from banks, job easier, and relieve the overall cost. But importantly, it will give ourselves. It's not like we are here now and we are still receiving calls from our hospitals that there's an emergency. Yes, this is about the last slide. So when we have mega practices, you have more time for yourself, time to relax without having the problem thinking that something bad is happening in your practice. So distinguished colleagues, these are the suggestions that I think we should act on now. Like I said, we have to create a future, and part of that is to think about these things and see areas where each and every one of us can fall in and make private practice better for the future. I want to thank the LOC once again for giving me this unique privilege to make this presentation, and I want to thank all ANPMP members from across the country for coming here for this conference. Thank you very much.